I'm very honored to be here at COMy and to be able to talk about the realistic possibility of cure of myeloma. So I'm going to talk about some of the new technologies that we use now to monitor myeloma, mass spectroscopy, circulating tumor cells, circulating free DNA, and even single-cell sequencing, not only of the tumor, but of the microenvironment. I'm also going to then talk about how we're going to use some of the drugs we already know about for different uses. So melphalan, for example, can induce mutations, which in turn can, in fact, be targets for immunotherapy. Bortezomib, the proteasome inhibitor, can induce an immune response in patients against their myeloma, immunogenic cell death. And the immunomodulatory drugs can actually trigger degradation of proteins. So a whole new class of protein-degrading compounds is coming to the clinic in myeloma and other cancers. I'm going to move on to new targets. One of them is BRD9, which is a target in the myeloma cell. There's another new target called EPRS, which turns out is in the microenvironment can overcome the high amounts of proline that are in myeloma patients. And finally, I'm going to talk about targeting the microenvironment. There's a new target, CD73, which is expressed in the myeloma and confers immunosuppression. I'm going to talk about how we're trying to do precision medicine in myeloma, targeting mutations, but it's difficult because there's so many mutations in myeloma, but adding in targeted therapies. So an ERK inhibitor to restore sensitivity to IMiDs, or a JAK inhibitor to restore sensitivity to CD838 antibodies. And then I'm going to talk about, obviously, the immune therapies and some new ideas about CAR T cells first. Can't we have a universal CAR T cell? The idea would be you give an antibody that has a label on it, daratumumab, isatuximab, elotuzumab. It labels the myeloma, and then give a universal CAR that only is activated and kills the cells that are already labeled with an antibody. That's one example. And then I'm going to talk finally about the bispecific T-cell engagers, which are really off the shelf and quite exciting because they bring the immune system to the tumor cell exactly where you want it, hopefully in so doing increasing the potency and decreasing the side effects. Finally, having said all of that, how are we going to get to cure? Well, this meeting has highlighted that we can use 4 drugs, a proteasome inhibitor, an immunomodulatory drug, steroids, and a CD38 antibody, with or without a transplant, and we can get high levels of MRD negativity. Then, as has also been highlighted at COMy this year, transplant would normally be done, but what's being done now in clinical trials are immune therapies, whether it be CAR T cells and or bispecific T-cell engagers as part of the first-line therapy in myeloma. So my prediction is that in 2030 we will cure myeloma, we will cure it by achieving MRD negativity, and importantly, we will restore the immune response in patients against their own myeloma. Cure then will mean free of disease and off all medicines. It's really the most exciting time ever for researchers, caregivers, and especially for patients.